all things specific to the birthing population. So I'm happy to be here. So I'm going to have our esteemed guest, Dr. Saida Pepra, introduce herself, and we're just going to have a very informal conversation. We're going to ask everyone, as you're joining in, to please go ahead and mute yourself. And if you have any questions that you'd really love for us to address, go ahead and put that in the chat, and we'll go ahead and get started. So, Dr. Pepper, you want to go ahead and introduce yourself?
Absolutely. My name is Saida Pepper Wilson. I am a licensed clinical psychologist. I'm a doula. I am the executive director of Diversity Uplifts Incorporated, which is a nonprofit that focuses on, really thinking about my background. I think as a psychologist, had me always aware that the providers and the state of mind that they're in and the way that they work with people really impacts their services. Their ability to be culturally competent and really present to what's needed on like a client-centered, trauma-informed model and mindset is going to make a difference in the way that they're able to be effective in whatever they are, whether they're a surgeon or a chiropractor, or acupuncturist, or a midwife, and even a doula. And so we provide diversity training, implicit bias, historical trauma, social determinants of health, trauma-informed care training for providers that work with pregnant and postpartum people, and also just people who work with people. So we do a lot for mental health providers, for social workers, and then we also have direct services through doula programs. And so we have community doula program directly called Frontline Doulas, and we have a cohort of Black doulas that serve Black families in Los Angeles, California. And then Diversity Uplifts, we support a number of community doula efforts, policy, sort of like consultation around ideas of how to build out policies that'll really work for everyone. So we stay pretty busy with the nonprofit and the work. And I'm a mother of two girls. One just turned 15 and the other one is 12. And so really busy at, motherhood and life in that way as well.
Sounds great. Well, thank you again for being here with us.
Thank you.
And I love all of the things that you're focusing on because all of it is so necessary and so timely. And I think it would be a really great way to start a conversation since your focus is so doula heavy. Tell me a little bit about, for those who are not as familiar as you and I are, about the role of the doula. Speak a little bit to the role of the doula and how the doula can actually interface with the birthing community as it relates to mental health and mental health issues. And is that a natural blend for them to have those kind of conversations?
Yeah, I was just talking to my program coordinator, Cafe Riley, about that. We were just saying how a lot of times people think of like the physical benefit of a doula. Oh, they can help with, labor support positions. And, but really, when we think of, I would say those of us that have been in the active birth work, for many years and have like made that life transition or that sort of life, sort of passion and ministry to be present to families that are birthing, it is a lot more emotionally supportive. It's a lot more, creating a space and a context for them to feel safe in their care. Both with us, creating a lot of rapport building and having all of their family members feel really supported and connected as well, but making sure that they feel ready to go into that birthing experience, that they understand things. So it's a lot of education as well. And I think that education, like as a mental health provider, psychoeducation is something that's used like a first line of like helping people deal with whatever they're dealing with, whether you're responding to like an emergency trauma response or emergency situation, or just like helping people cope with daily issues with their family. It's like, this is what's normal. This is what's out of the range of normality. This is really typical at this stage of pregnancy. And, and so normalizing for people really helps de-escalate a lot of the anxiety, and anxiety tends to be something that is really high for people when they're pregnant and postpartum. And so the doula is very much this like natural presence to help the entire experience feel better. And then when you feel better about things, you feel more comfortable. And when you're more comfortable, you can ask more questions. You notice things more with your own body and your own experience because somebody's asking you, they're interested in you. And then the doula, honestly, especially community doulas, there's a lot of navigating the healthcare system that's really difficult for people in general when they're just trying to figure out, like, where do I go for this provider? And, do I have choices? And what kind of insurance do I need? And doulas, because they're working with pregnant and postpartum people pretty much every day and talking to someone, they're also navigating different hospital systems. They're operating within and outside of the hospital. So they know a lot of the local midwives, they know other doulas, they know the OBs that patients and families on the ground, not just like on Yelp or on like, some like, or the hospitals, list, but like they know from word on the street what doctors are disrespectful, what doctors, are really encouraging, who really encourages, the family to also have a doula, and who is really going to be able to provide them, the kind of birth that they're looking for. And people are looking for different kinds of births, and doulas can also help navigate that experience for people as well.
Yeah, so that sounds great. And I definitely value doulas as a nurse and a nurse executive who's working in that space. I understand that, the more people you have, that's part of your support. Again, the less anxiety you have, the more relaxed you are, the more supported you feel. All of that really adds value because we know that if you're already feeling anxious, and I think most pregnant people feel some level of anxiety because there's so much of an unknown during pregnancy, especially when you're in labor. So it's a natural tendency to feel that anxiety, and the more support you can have, knowing that you have somebody in there that's going to amplify your voice and stand in the gap for you and ensure that everything that you had planned for your birth, as much as is possible, is honored. I think that definitely decreases some anxiety that birthing people have coming into the space of the hospital. And definitely healthcare is complex. We talk about that at Antonia and Grace, that navigating healthcare for healthcare providers is complex,
Absolutely.
right?
Yeah.
We struggle, so you can only imagine that the public struggles as well. And how do you eliminate the barriers, and how do you make the pathway as simple and as easy for everyone as possible? That's definitely one of our objectives at Antonia and Grace. So we are so aligned. So as we talk specifically about maternal mental health, um, overall, do you think that in our current process and in our current practice, do you think we do a good job at recognizing and intervening, and then intervening in a holistic fashion for the birthing community? Do you think we're doing a really good job on that? You willing to speak a little bit on that for us?
And when you say we, you mean like the general healthcare system?
The healthcare system. Yeah, I take ownership for everything that I do. So I am the
No,
hospital. I am
I
the healthcare.
wouldn't. No, I wouldn't take ownership of that. I would just, own the part you're doing, because I feel like you're doing
There
something
you
different.
go.
I mean, you're doing something different and innovative. That is why the general healthcare systems aren't working as well, because they're not as focused on like what's the response to what's actually needed isn't there as much, because people aren't really invited so much to have an impact on that, right? Like they're not asking like general families, like, okay, we're creating new policies for the hospital this year. We want the community to tell us what you think we should do differently, right? They're just talking among themselves a lot. I think generally, when I think of the US healthcare system, because I've traveled a lot and I've been fortunate and thankful to be able to see other parts of the world in the way maternal health looks. But also I have friends that have lived abroad and people that I know who have birthed abroad. And then, just in all the research that we do as we're looking at what we see here, and, we're looking at the disparities, and I'm like, okay, that's interesting. I always want to know what's behind this. Like, what does this look like beyond just like the narrow view? I feel like I've learned that in working in big systems, but then working as like the direct provider, that if I don't understand what the bigger picture is, I can't really do as much help to change the system for the individual. I think that when you see like how we compare to other first world nations, just in how we care for mothers and birthing people in general, there's some like key things to the US that are very distinct. We have a over representation of OBs over midwives, right? And so the midwifery model, just when you're thinking like, well, why is that? Is it that OBs are terrible? Well, if OBs are specialized in, really doing, they are the ones that do the surgeries when it's necessary, right? They do C-sections, they do, very active medical intervention, and they have really important skills in that. But we're wanting people to not need that as much. We're wanting that to be the least used option, because the more you intervene, the more risks there are. Obviously, when you intervene, you need to intervene often, hopefully, because there's a reason. But when you have, a workforce that's also then influenced by liability more than patient care, that's influenced by finances more than patient care sometimes, that's influenced by pharmaceutical companies or whatever the things are that are all of the pockets that the major system, which is like the hospital systems, think about all these other factors other than just the family. Then you start having these competing things, where in the midwifery model, you have this holistic intentional care where they're spending an hour versus just 15 minutes, with a person. So you have a whole hour to figure out their emotional needs, their social needs, their full-on health needs, to hear the story of what happened with their mother, and maybe that could be influencing this. Like, no matter how amazing you are, you can't capture the life of a person, especially in pregnancy, and in the multi-generational impacts and how, social determinants, all the things in 15 minutes, right? And especially in like the major systems where, those of us that work in community mental health and community health with doulas and beyond, you're looking at clinics that are seeing 3 or 4 or 5 or 10 times more than a private OB who's seeing people with private insurance would see. And so they're getting even less attention, right? And so when you look at that, and then you think of like all the needs that you would have to need to be supported just as a person that's pregnant and postpartum. Then the other thing is that we don't have paid parental leave for fathers or for mothers, right? And so we have a system where some jobs provide it, some jobs don't. You might get a part of your pay if you have the government one. If you live in one of our nice states, you might maybe get 12 weeks. And in other places, it would be like a catastrophe. Like if they made all the people who are having babies only have 12 weeks postpartum, that was paid and, supported by the insurance system, their whole infrastructures were shut down because they have a year or more. And not just that they have to have a year of having paid and then they, have their healthcare. They have healthcare that's available, right? People don't have to hope that they're going to have healthcare when they're pregnant and postpartum. And even that isn't like 100% accessible to everyone. And then, of course, what we determined to be the postpartum period here, where now, like a lot of the advocacy, like it should be 12 months. I mean, 12 months rather than just 12 weeks, right? And so, or just 6 months. And so some of the systems that we have that are our general health system just don't support people who are pregnant and postpartum. Like they just don't, like if you were trying to support a person that gave birth and then needs to recover and heal and then care for a baby and then have the support of the family and then make those financial adjustments, you would create a space for them to do that. And because we don't have that in our system, you're going to have whatever that would look like on top of the sort of physiological reality of childbirth, which is that certain percentage of people are always going to have or potentially could have C-sections because there are certain kinds of complications. There are going to be people who develop perinatal mood and anxiety disorders because there's chemical imbalances that happen in a certain percentage of a general normative population. If you stress them out, if you don't give them support, you're going to have more stress, and stress is going to create even worse things, both in healthcare and in mental health. So I would say, no, I don't think that we do a good job of just creating an environment where we could thrive. But then if people are having a hard time, then the question is, where would they go, right? And so the fact that they even have to go somewhere to get help versus in a lot of the other countries, they have home health aides and they have home nurses and they come to the person in the postpartum period, which mitigates transportation access, exhaustion, the reality that if you really get into a difficult mental health state, you're too depressed or too anxious to engage with other people in a lot of ways to really actively advocate for your own healthcare. And so then a lot of things get missed. We don't have standard screening processes we have standard screening that exists, but we don't standardize how they're done or who's doing them. And so that gets to be a hit or miss. And then we have like a very small percentage of people that are serving the perinatal mental health community that represent the community that have high disparity. And so Black folks, brown folks don't have providers that they can find in their area that look like them, come from their communities. And so the existing racial disparities, racial incongruence, not just because a person is Black or white, but because America is still America. People live separately. People sometimes are integrated and connected and, affirming and loving. And very often people are segregated and siloed, and they only know their own experience, and they're very limited in their ability to understand another person's life experience. And so people don't feel comfortable. They don't feel heard. They either don't go or they go and they're like, no, there's no way that I can like talk to this person about all my business because they can't even say my name right, or, create a space where I see myself on the walls, right? Like in pictures. And then, so we don't have a lot of, and we just don't have a lot of screening happening for Black and brown folks who have high disparities anyway. And so, no, I don't think we're doing a great job on that one either. People are working on it, but not
Right.
yet.
Right. Yeah, that was great. You said a lot there. And I think a lot of it is not just the relational issues, but there's also some significant systemic and structural issues that has to be fixed. So it's important for everybody to recognize it's going to be a multi-pronged approach that's
Yeah.
going to take a lot of time. We need to first dismantle our current processes. Dismantle is a nice word. We need to blow it up.
Yeah.
is how I think about it. We really need to blow it up and start all over again. And I appreciate the comments you made about changes that the healthcare system will put in place without the voice of the customer,
Yeah.
especially without the voice of the Black birthing community and saying, this is for you. I speak a lot on that because, and I call it arrogance at its best.
Absolutely.
When a homogenous group thinks that I can fix the issues of the community without having the voice of the community, that's the best definition of arrogance. So yeah, there's a lot for us to do, and I appreciate that. So what we know from literature, lay and even peer-reviewed literature, is about 700 women a year die from pregnancy-related causes. And layered on top of that, we know that, Black and brown women are 3 to 4, sometimes 4 to 5 times more likely to die than other women. We also know that these pregnancy-related causes, that 60% of them are preventable.
Yeah.
Right. Which speaks to, I won't say us, I will say us, which speaks to the healthcare system that, we have really huge opportunities. I was reading something recently that said that 1 in 9 of the pregnancy related deaths has a mental health component to it. So as we think about prevalence, would you agree with that number? And is there that disparity as well with maternal mental health that we see with overall maternal mortality for the Black and brown population?
Yeah, there is disparity with maternal mental health with Black and brown. There's been there haven't been really extensive amounts of research that have looked at the sort of racial and ethnic group comparisons to really, I would say, for me to feel like, oh yeah, we have a really clear picture of that, because it's like, well, where did they do the research and who did they ask? Like,
Right.
How many people was that? What was the comparison of where it was? Is it regionally based? I mean, there's just so much dynamics when you look at communities, but we certainly do see pretty consistently that all of the research shows that there is a disparity for Black women in particular. They have higher rates of perinatal mood and anxiety disorders, so depression, anxiety, and beyond. But what is interesting is that there may be higher rates, and what I have found, like in focus groups that I participated in as like a support to the researchers, is that they're asking people, like, sort of after they've had their child, recount how you felt, right? Like these, where they're trying to assess on the back end,
retrospectively,
did you have a PMAD, a perinatal mood anxiety disorder, when you were pregnant or postpartum, which was obviously missed, and now 5 years later, you're telling us your story. And that's kind of what the research looks like a lot of times, is that it's not like there was an assessment, that these are like diagnostic research, findings, that it's, sort of after the fact. And what we do know from research is that people are not being diagnosed or treated as much as they're being identified as having a disparity. And so, if you have a high disparity in Black and brown people, you would think that they'd be treated more than other populations, particularly white populations, and they're not. And so we have a disparity on multiple ends. And I think that, the opportunity to have more conscientiousness within our own communities around how we could screen ourselves. Like, what does it look like for us to take that in hand? Because, very often, as much as, and I do a lot with like supporting, ideas for policies to come out that can help better, and for hospitals be thinking through things, and for small community organizations. But as much of the work that I do, like systemically, I am always like, and the shortcut to this could be that every Black person and family member and auntie and grandma and church and, community center knew how to care for pregnant and postpartum people, and like what it would take for them to have what they would need. Like, so you see somebody's pregnant, that means they're going to need 40 days of food and nutrition afterwards. So who's going to do that, right? Like, yes, it'd be amazing if the systems did that. In Germany, where my brother lives, and his wife, she had, by the insurance, a postpartum doula, a pregnancy doula, a nurse come to her home. They pay her to breastfeed. They have supplemental money for every child that they have. They get extra money because you need extra food, you need extra nutrition, right? All of the healthcare is free. So she doesn't have to compete for the good vitamins and the organic food. All the food's organic, right? So, I mean, she's in a system where she doesn't have to sort of like figure that out. But if we're in a system where we have to figure it out, what if we could figure that out for ourselves, right? And I mean, I think, Antonia and Grace is a great example of that. Our organization, with Frontline Doulas and the things that Diversity Uplifts is supporting is often like, how do we get the high level people to do stuff to shift it? But until then, what does that look like on the ground, And so, especially for screening, the Edinburgh and like the PHQ-9, which are pretty typically used for assessing, maternal mental health, something like the Edinburgh is available online. It's free. It's actually a self-assessment that the doctor might give you, but actually it's your questions for you to do. And so I really empower, and have for many years, for the doulas to provide the Edinburgh to their clients, so that while we're talking about, here are the things that can happen in, early labor, and, the transition, and then pushing, and then you're in the postpartum period, and what to do for your first 40 days. And here is also things to know about your mental health, about baby blues, about what it looks like if you go a little bit on the spectrum of you're having a really hard time, right? How do you make sure? And then give them the tool to assess that for themselves, and to have that they could say, I did it at Edinburgh, and come to your OB's appointment and say, I scored a 15, right? Like, it says on here, I'm supposed to call somebody. Are you somebody? You know what I mean? Like, actually, and so I think that if we think about how to put it back in our own hands, we can make the adjustments that we need while the systems do whatever they do. And I'm sure at some point we'll get there. I mean, I love the idea of like blowing it up and dismantling it and putting it back together. Because that does need, the way it exists now, like there's so many barriers to go through to get the things there. It's like, can we just start again and maybe adopt the things that the other first world nations are doing that work, right? I mean, like, it actually doesn't require like no, like a whole new think through. I mean, I think there's opportunity for that, but there's a systemic way for them to just think of like what's already working. And that includes the community-based organizations that are working, right? Like, there's local versions of what's happening on an international level that is working at certain clinics because of how they do like whole person care. Obviously, the midwives that are working in America all over have different outcomes. So when we talk about the outcomes of maternal mortality and a lot of the morbidities, we're only talking about hospital births. Like, if you look at midwifery model outcomes, you don't see those same kinds of things.
Right.
And there are a lot of factors for why that would be, but one of the biggest ones is that there's such a close hold with the midwife and the family, and a monitoring and an attentiveness and a use of other people in the network, that you're catching things and you're supporting things, and those families are not alone. I mean, you're spending a lot of time with them, become like a family member to them. And of course, adding doulas to a team like that, or having doulas in a hospital team means that you have someone who's more connected and knows a little bit more about what's happening with you and can help you navigate those things as well.
Yeah. I love what you said about the community really stepping up to support Black women and Black birthing people, and especially when you talked about the church, right? Because I'm a church girl, grew up in the church, and I know for a fact that the views that the church has could be incongruent with what the science shows, right? Especially in the Black church, it's like, well, you should pray about it, well, let's go ahead and try changing your diet, go on a fast, drink more water. There's so many things that the church says that could be potentially harmful. And when I think about what you just said, what would, again, reimagining what a support could look like, what would it be like if the church would respond the way you mentioned that, oh, hey, our member is now pregnant. How do we rally around her to offer that support? I mean, that blows my mind. That would be so incredible.
Yeah.
And anyone can start that. Anyone can
Yeah.
start that in their church and say,
Tomorrow.
hey,
Yeah.
exactly. You
And
don't
it's
need
like somebody,
permission.
yeah, and somebody
Right,
local like you, let's say, who's in this field, you're in
right.
proximity to local churches, and for
Mhm.
the Muslim community to the local mosques and to, there are people within the community that work in this work, right? Like they're
Mhm.
working with pregnant postpartum. People ask, like, who does work with our pregnant population, and what could we do as a spiritual community and as a community center to make it so that we are a place of support,
Right.
And I think, it's interesting because, it comes up a lot in the conversation about like, is how helpful or harmful is it? Like this idea of like, we'll just pray about it, right? And I think, what we do know in mental health is that prayer and like religious and spiritual beliefs are protective factors for mental health, right? Like it will often, if I'm doing a suicide risk assessment, and I spent a lot of years in suicide prevention and intervention, so people at the psychiatric hospital and in any world that I was working in, whether it was community or in the prison systems when I worked in the federal prisons, I was very often the person I've been very well trained in suicide at work. And one of the things that I look for is whether or not a person has spiritual and religious beliefs, because it tends to give them, it gives me a sense of like, where can we pull hope and faith and opportunity for resilience from? I mean, it's a really strong protective factor. But in and of itself, isolated from what is a normal expectation for a person to have who's pregnant and postpartum, it's like saying to somebody who's starving, like because they're not getting nutrition, just pray about it. Like, yes, you come with prayer and a meal, right? Like you're not
Right.
just gonna come and do homeless services and talk about, we're just gonna ask God to support right here while I'm gonna go home and eat my food. Like you
Right.
go home with support, bring support to the people who need the support, and let's encourage and bring in the spiritual practices, to make that holistic. To me, part of a spiritual community is also the community. Like the spirit is not just prayer, it's also in the
Right.
work of working with each other. And I think, dismantling some of the, like, it's just more that it's a taboo and it's uncomfortable for people. And so it feels like, oh, well, we don't know about those psychologists and those therapists over there. Like, we just know this part because this is what we know. This is home, this is family. So get to know it, because there's people at the church who are therapists and psychologists. And I think, in my degree is in multicultural community clinical psychology. And when I got my psychology bachelor's at Spelman, I was also a religious, basically like a double major, and did religion and psychology together. And so my entire practice has been a lot about looking at faith-based and connecting it and working with people in their own cultural congruence, which is often spirituality. And we really do have way more of an opportunity to infuse those, but people need to understand like each other. And so I've seen some churches set up therapy offices in the church, and it's life-changing. I mean, it's like the whole community is now coming because they're like, oh, the pastor said it's okay to go to therapy. And then they're like, oh, therapy's not witchcraft. They're not trying to get me to do
Right.
whatever it is, whatever, the challenges are. Like, it's just a person like the deaconess who sits and talks to the women at the women's meeting. And I'm mentioning that because I remember my neighbor was a pastor when I lived in Virginia. And I remember how active the deaconesses were in that church with like family stuff. Like you could go and get an appointment with the deacon and the deaconess, particularly like the deacon's wife was like always busy with like family and women stuff. But if that person was a therapist, or that person was consulting with a therapist, or they did stuff together, and I've seen church communities in particular do that. And I've also seen mosque communities have, adjacent, mental health support as well. It becomes like the go-to rather than taboo, because you go to your spiritual community and your spiritual community is endorsing other social supports and mental health. It feels like this is a part of my spiritual journey. And then they realize it is once they get in there, because, There's a lot that can be incorporated. And there's a lot of therapists that incorporate spiritual belief systems and will use your belief system as a part of your interventions. So yeah, talk about that forever.
Which is great. So everyone who's listening, go back to your communities and start having these conversations, because we really need to normalize. We need to normalize talk therapy. We need to normalize counseling. We need to normalize couch time for everyone, because again, we need that support in the community, and we can definitely do that. So that's one big takeaway. Another really big takeaway, thank you so much, Dr. Pepra, the midwifery model of care is a thing of beauty, right? In case you didn't know, midwives, we have data on midwifery outcomes dating back in the United States to like the 1930s. So FYI, midwives are not, Johnny come lately to healthcare, especially granny midwives for the Black population. We've been at this for some time, and the midwifery model of care has really great outcomes. Significantly less cesarean sections, higher exclusive breastfeeding rates, better bonding rates. It's so many great outcomes. So something else to consider and to tout and be really proud of for our community is that midwives make a difference. Do we have enough midwives who look like myself and Dr. Pepper? Not now, but Jenny Joseph and her midwifery
Jenny's working on
school.
it.
Yes, and other people who are working on that. That's going to start.
There's a bunch of them out there that are really working on, sharing that and have.
So that's going to start changing. So two things for everyone to take away. So let's talk a few specifics, if you don't mind, Dr. Pepper. Share some examples of what does perinatal mood and anxiety disorder look like, so that we can all be informed and recognize it and intervene sooner than later.
Yes, sooner than later, because unfortunately, a lot of people, first of all, that's a perfect segue. A lot of people think that it's just postpartum depression, right? Like it's just something that's happening after you're pregnant. After the baby. And so people are really looking to start doing something about it after that, or even assessing for it after that. So you see a lot of missed opportunity to even screen earlier. But the occurrence of depression and anxiety in the pregnancy period is pretty much matched with what we see in the postpartum period. So people are extremely anxious. They do meet clinical significance. And when I say that, it's like, that they actually, really could use the support of another person, of, a therapist, sometimes of medication, but that they're not coping okay by themselves, that it's not just resolving on its own, that it's not like a small sort of momentary situation. We have not just depression and anxiety, which most people are really familiar with. We have postpartum psychosis. There's, obsessive compulsive disorder that can be related. People can have, post-traumatic stress disorder related to the postpartum and pregnancy period. And typically that comes from some kind of birth trauma that has occurred that is unresolved, that they didn't understand why it happened, that they, and I say that because it's, I have, in the work as a psychologist, there's oftentimes a very short window of opportunity to make sure that people don't get PTSD when they've experienced trauma, even when it's really terrible. And so one of the things you'll see like in, sort of like major catastrophe, trauma intervention is that if within the first 24 hours, you can get to the person, you can talk to them about what happened, you can have them process the story, answer any questions that are confusing, because a lot of times when traumatic things happen, you don't remember, you're confused, you're overwhelmed. And then you're able to normalize for them. Like it's probably going to be difficult to sleep. You may feel like you want to do a lot of high risk things because you're just overwhelmed and you just want to get some energy out. It's better to go to sleep. It's better not to drink alcohol on this first week after this major trauma. People tend to want to self-soothe. It can be really bad when you're having trauma and trying to self-soothe because your mind doesn't feel like it's able to cope. And then if you introduce alcohol or drugs, then you can get a dependency and that can make it worse. And so like there are ways that we can do like a really nice, like we call it like psychological, first aid in trauma, where you see a huge difference in people that end up having PTSD versus those that say, I had this really traumatic experience, but I'm doing okay. Like it was hard and I went through it. And so and I think about that a lot for birth, that, you know, women and people have these pregnancies where they have an unexpected thing that happened, that they feel that they were maybe sometimes, you know, to the extent of being abused in some, excuse me, in some way by the provider. And for an example, like an a episiotomy without permission, right? And so somebody is saying, well, you know, maybe one where you were telling them, no, I don't want to be cut, and they're still cutting, right? Like we've had examples of that where it's a really active, engaged personal trauma, but can also just be, you know, someone we often talk about in the doula world, people who have these really precipitous births and they have labor really fast and they don't realize that they're about to be pushing out a baby. And that whole experience of like, they thought their water was going to break and then they'd have some time. And then suddenly they just like, you know, contraction after contraction and it doesn't stop. And then they have a baby really fast and they thought they would be able to get an epidural. They weren't able to get an epidural because it was, you know, just too much happening.
Right.
Or I was in a session the other day and a woman had an epidural, but it was a failed epidural. And so she was feeling it all and had really, her coping, excuse me, her coping was, you know, in her mind, I'm going to cope as long as I can, and then I'm going to get my epidural and I'm going to just sit back and have this baby, right? And so that was how she had set her mind up. And then when she got to the birth, because she had not planned to have a labor that she would feel from start to finish,
right,
that was extremely traumatic, you know? Now, people who are dealing in natural birth every day are like, oh, well, that you could do that. But the mind isn't like that. It's what you prepare for. It's what you're ready for. It's what you're expecting. And so there's so many things, you know, you expect to have a vaginal birth, you end up in a C-section, you expected your baby to be healthy, the baby had challenges, you expected to go full term, and now you're having a baby at 6 months and your baby's in NICU. I mean, and if you think of the Black community in particular, because we have a number of like statistics that show disparity, that we have more low weight babies, we have, you know, more preterm births, we have, you know, more C-sections, right? We have more hypertension in scenarios. And so then people, even if we have more near misses, right? Like where you almost die. And that in the trauma world is basically the same thing, is, you know, seeing somebody else die or having like, it's there's no difference for the mind in the trauma of I almost died when you wake up and, oh, I didn't. You still experience the entire trauma like you were going to, right? And so all of those opportunities, like if you think of, if we have all these disparities, are all these people getting therapy after that, after they lost their baby? Do the partners get therapy after they lose their wives? If we're having, you know, 3 to 4, you know, and I think New York and DC, it was like 12 times more likely to die than the white population. Did every one of those family members get support? No. So we have high disparity. We don't really have a system of like immediate sort of automatic response, even when we know, because we know all the high risk factors for maternal mental health: C-sections, multiple births, unexpected, you know, birth scenarios, birth trauma, not having a partner, parenting single, unexpected, you know, poverty. I mean, you know, we name all these things and we're like, yes, we realize that the Black community has higher rates of this in a lot of the pockets. And so what, even if you, and we know this, you know, with the maternal mortality rates, even if you have, you know, a high socioeconomic status, you have a partner, your rates of having maternal mortality are still higher than a white woman who didn't finish high school. And so when you do that, then you say it's not, we're not even just talking about the poor populations in Black community. We're not just talking about those that recognize or could be recognized to have, you know, high, you know, social determinants needs. We're talking about the whole community needing more, right? And then we're back at, do we have those providers? Are they accessible? How much does it cost to get a therapist? I mean, like here in California, among all my peers, if I meet a Black person, I was at the Perinatal Support International Conference just a couple of days ago. I think I got back yesterday. And so all the Black women, well, the Black providers, I think we had 2 men in the house in the whole thing. You know, we got ourselves together, and also with other women of color and providers of color. And we were like, where are we? Who are you? Do you have availability? Are you actually taking clients? Most people are full and they have, you know, their calendar is full, you know, for the next several months. And it's difficult to get people that take insurance, certainly almost impossible to find people that take Medi-Cal for California, Medicaid, you know, for other places. And so you know, we need like a lot. We need a whole new strategy. And I love that, mentioning the midwifery model, mentioning how communities can support, because a lot of the needs, if somebody comes into the psych hospital with a psychotic, symptomology, which is, really extreme, the first thing we do is make sure they sleep in that first day. I mean, those medications are about, and this as a nurse, like, when do they sleep, right? And it's like, we have to get them to sleep, because if they don't sleep, even if you just sleep deprive the general population, most people will become psychotic, right? And so we know mothers they're not sleeping most of the time, and especially not if they're by themselves or if their partners have to work, and all the things. So, yeah.
So, as we are almost out of time, believe it or not, let's talk about some, because we always want to end with hope and with some solutions and with some, some fairly easy way for us to intervene to support Black women. So I think you've done a really great job just saying that, again, maternal mental health is underreported. We don't have a really great processes for ensuring and assessing, nor do we assess regularly. We don't have a lot of providers who look like us to provide this service. So we know what some of the barriers and the challenges are. But as we think about solutions, as we think about what all of us listening can do to be a support, one thing that we say at my organization, it's something that we've embraced, especially as it relates to trauma. We say that trauma is whatever the birthing person says it is. That we can't define what the trauma. Having been an L&D nurse for so many years, I totally get it. So how do we share hope for those who are listening, for our communities? How do we become part of the solution? What would be like your top 3 go-to to say, okay, let's do this? What would you say?
Well, I would say, for those that are support people to pregnant and postpartum people in any kind, if you're a nurse, if you're in-home, peer counselor, lactation, doula, anybody, have the Edinburgh, and I'll just use that as an example. I think it's a very, layperson friendly and really client friendly tool in your pocket on your phone, so you could text it to someone, and have that be a part of your model. It's something that we're putting out there for, the insurance systems. We're asking, policymakers to do this. The maternal mortality review committees that a lot of us sit on are putting that out there as a recommendation. But if you have that as, you have a screening tool that you could give, if somebody's having a hard time and you're not sure how hard of a time are they having, it's probably the most common thing that people will ask me. I feel like there's something going on with this person, but I'm not really sure, what if it is. I always say, if you think it is, it probably is, right? They probably need help, because you usually don't have a lingering feeling like they need help if they don't. But then you could offer that, right? In the way that feels most congruent with the person and the program and things like that. Or, provide it to them that they could do for themselves and give it to a provider. I would say, creating innovative systems, just out of the pocket, think out of the box, try to come up with, yes, these are the things that will be great if the system works, and keep pushing system, keep, doing the focus groups and doing innovative ideas. But in community, let's come up with ways that we can do things to support. Because if you can get the social supports there, we know that people who are more socially supported have less, stressors, and they have less, it's a protective factor against maternal mortality, maternal mental health. And so come up with ways that you can support pregnant and postpartum people. If that's diaper drives, if it's but just let this be something we're always thinking about. People always think what to do with the elderly. And I don't know, there are topics that always come up, that let pregnant and postpartum people be people.
Like smoking cessation.
Right.
Stop.
Exactly. Don't let that be on your list. If you have a sorority out there, I'm a Delta, by the way, but if you have a sorority out there and that's what, you have the opportunity to make an initiative, put pregnant and postpartum people on there, and especially Black folks, because we have high disparities. And then I guess, for the birth workers out there, know each other. work together more. Like so many of us have things we're doing and we don't know that our neighbor doula or midwife or the OB clinic or the nursing organization, like find ways to work together better so that the clients that you serve can get the things that I give. And even if it's that somebody does a local, diaper drive at the local spiritual center, but
Right.
you could tell the hospital clients who are in the postpartum period and you're about to send them off to the world, good luck with your life, that there's a place that they could go to get support, right? And so, but if you don't know community supports, if you're like a big organization and all you know is your hospital's little referral Rolodex, that's not a warm handoff, then you
Right.
really can't make any changes for people. You have to know who's there in the community and then find ways to collaborate. And so give people the floor, let the local doulas do a meet the doula day at your hospital, and like find ways to collaborate, across, the systems line so that it's not as difficult for the families to navigate, because it's hard. It's hard if you're educated and informed to figure out like what to do once you get pregnant, let alone those that have any barriers.
Mhm. Yeah, and I would mention also some of the nonprofits like, Healthy Mothers, Healthy Baby here in Georgia. They're very, very active. They're always looking at research studies. They have a doula work group. They're always putting on events to help inform the community. Look for somebody like that. Center for Black Women Wellness is another great one here in Atlanta. They're great. I don't know if you want to talk about Black Mamas Matter Alliance because they're
Yeah,
having a big
definitely.
event in October.
Absolutely. I mean, Black Mamas Matter Alliance, and, if you're anywhere in the nation and you're looking for community doula programs or programs that focus on Black moms, if you start with BMMA, there's a map and you can see which states and you can sort of find who are like the people that are really connected to the alliance. But that puts you in a network of folks that are really, very strong about birth justice and reproductive justice and aware and communicating among each other. What are the best ways to serve our people where we are and what are you doing and how? So there's a lot of innovative intentionality among the alliance to serve families. And so, yeah, definitely a great resource. And of course, there's the Black Maternal Mental Health Week, which, Kay Matthews with Shades of Blue will be doing a lot of programs on that. I'll be there later on this week too, and some of the webinars, so you can check us out there. And be in these conversations for Black Maternal Health Week, which is in April. And then, we have Black Breastfeeding Week in August. I mean, just stay
August.
tuned to all of these,
Right.
really awesome. And then there's the conference, which I think I heard is sold out in person, but the virtual conference for Black Moms Matter Alliance should still be available, and that'll be in September. So lots of opportunities to connect to the alliance too.
Yeah, that sounds great. And I think for our next session, Marie, we should probably have some written resources like, Rose is another great resource, Reaching Our Sisters Everywhere.
Oh yeah. Oh,
Um,
definitely. Yeah.
yeah, there's so many. And then we have Rogue, Reaching Our Brothers Everywhere also.
Yeah.
And also the
Oh, but then resources, right. So if you're looking for maternal mental health resources in general, definitely, I mean, Postpartum Support International has
PSI.
a line, and they actually have a new like live line. So you could call and talk to a person and not just like sort of the referral system where you get a person, they can tell you how to connect with someone locally, but both of those are available. PSI, I think it's postpartum.net is their, or maybe postpartumsupport.net. We'll put it in some notes somewhere. So people can know. But they also have online support groups that are for women of color, for LGBTQ families, for fathers, for if you have a baby in NICU, if you have, if you have perinatal loss. I mean, they've really created a robust set of online birth support trainings as well. And then Sisters in Loss for those, because a lot of people who have postpartum mental health, it's also because they lost a baby and they've had perinatal grief. And so Sisters in Loss is a really awesome organization. They have a podcast, Erica McAfee, but they also have online support groups as well for particularly for Black women and other women of color, and it's faith-based that, have experienced loss. So some good resources there.
That is fantastic. We put a lot out there, and I see that Marie said she's already going to partner with you and get a list of resources that
Sure, I will. Yeah, I'll send it over for sure.
We'll definitely share with our attendees and share on our website as well, because we are committed to being part of the solution, definitely. So I'll just give like a minute. Does anyone, Marie, were there any questions, or Lauren, any questions in the chat, or is it primarily comments? Because we have like 2 minutes for a question if anyone wants to address something directly to Dr. Pepper or to myself, would be happy to entertain that.
And actually, this is not a webinar. It's a Zoom, so folk can unmute and turn on their cameras if they'd like and engage.
Absolutely.
We can have a party. Is that what you're
I know
saying?
my kids are at camp this week, so I've got.
Ooh.
I'll be the first. I will turn on my camera if you guys don't look too hard.
You're gorgeous. Stop it.
I love Dr. Pepper, the comment that you made about, and I want to understand the importance of the 40 days when you said, because it was like, oh, that must mean something. Because my daughter, when she had her twins, her husband is Chinese.
Yep.
And there was.
Yeah, the Chinese have a very distinct cultural practice.
Oh, her mother-in-law was like feeding her
all day long.
Yeah, this stuff. And I was like, it was, but I mean, her milk came in and they are very, so and when I was complaining about it to a friend of mine who's Ghanaian, she was like, girl, shut up. You just don't know your ancestor.
I was going to say that's super African, like it's super Caribbean. Like,
and she humbled me. And so I just was quiet. Yeah. And then the two of them, the little Chinese woman and the Ghanaian woman, were comparing what the little Chinese woman was putting in the stuff. Yes. So there is a whole thing to it. And there were so many similarities apparently.
Yes. Yeah.
And so I love that concept. And I could see, I mean, from a faith-based perspective, coming from a minister's daughter, I could see the church is really leaning into that.
Yeah, I mean, you know, if you look at the models that exist, and I'll say, I love that you gave the example. I always give this example. My friends laugh at me, like you and your Chinese neighbor, because when I was pregnant for my first child, my neighbor right across from me was a Chinese woman and new immigrant. So like, you know, she could speak English. They were well-educated couple in the sense that they had learned English back home. And so but they were new. They were, you know, pretty fresh, you know, in some ways to America. And they, when we were pregnant together, and our babies are born a week apart. But when I came home to myself and just doing the best I can with what I had. And she went to the mother's home. And I was like, where are you going? And she was like, well, you can come and visit me. And so I go, I must have, you know what, she must have had the baby first, because I went there and I wouldn't have been out my house after I had mine. And she was in a room. There was a woman bringing her food all the time. They made them walk all the time. They brought the baby to them so they can nurse, and they took the baby so they could sleep. 40 days, you know, and every one of her friends and all the people that she knows, she's like, that's just what we do. We go to the mother's home after we have the baby. And so I learned from that, and I was like, oh, this is really serious. I had heard about, and I had lived in Ghana, and you know, as you mentioned too, I think you meant talking about a Ghanaian woman, right? I had lived in Ghana and had talked to a lot of people about like what were traditional practices, and certainly we have this in most traditional societies, that the 40 days after a baby is born, that the mother is typically in a confinement period. Not that they're trapped and in jail, but they're allowed to just rest. They are fed. They are, you know, bathed in some ways, like, you know, they may even be like rubbed down by, so you don't, because some of them don't believe, some of the cultural traditions don't believe in full immersion bathing for a certain period of time, and just like letting the body rest. There's, you know, there's a hair covering, there's a, you know, doing things to fully bring back the nutrition of the mother, so that all that she has to do is feed the baby and sleep. Yes. And the fact that we've lost that across this like industrialized society. And why did we lose it? Really is because they want women to go to work. Like there's nothing else happening that's so important except, oh, you're supposed to be a productive member of society, i.e. make money. And so in a capitalist society, it's unusual that I wouldn't expect a capitalist society to set up a system that allows for that. But because we have that system, we have to really think about, how do we take that back as women who this is our experience? The people leading the system aren't having this experience. They're just watching, maybe their wives go through this experience, and then they're taking care of them. And so then they, you know, as in financially, and so, oh, I'll get you a nanny, or I'll get you a housekeeper. And so if you think of like who's creating systems and who are they thinking about that are experiencing the system that they're creating? If it was just for like, what is created by the system that exists, if that's all you had and you were just a single person having a baby, you would be homeless if it was left to the system. I mean, really, like you would have no way to pay for your bills. And if you didn't have a partner that could find a way to hustle to help, you know, and so, yeah, it is a huge opportunity. There's one organization in California that actually started off, their whole thing is about like this fourth trimester, which we call it a lot of times, where they are doing meals. So they're taking donations just to feed women, particularly Black women, for the first 40 days. And so they bring live hot foods and they get the restaurants to actually, donate and support, or they pay them through the donations. And it's pretty incredible. It's something that we kind of piloted with our COVID-19 initiative with Frontline, because we were like, man, there's like a food shortage, you know, as far as people going to the store, and then how are they going to get out their house with COVID and their baby? Like, we were like, how are people going to eat? You know, like, and then that's the worst thing if you don't have nutrition postpartum. But the churches, to your point, faith-based communities, I mean, imagine if you had a mother's home and this, even just the members of your church could all come and have 40 days. And I mean, I think the members themselves would take care of it. I think the aunties and grandmas and the big mamas cooking, and people would be so excited to hold the baby so she could sleep. And, you know, and the nurses who work at the church and people who are just knowledgeable could provide that support. But these organizations are run, they're not medical centers. These are community women, and they just are there as mothers and grandmothers and aunties, helping these women do the thing that they had to do so that nobody has to do it by themselves. And then they just go home and they're like, I'm great. I feel lovely. My womb is healed, and you know, my baby's feeding, and any problems that they have, the lactation consultant is the woman who breastfed all her 9 babies, you know? And we have lactation consultants. We actually have people in the community. You could assign a lactation consultant to that mother's home. So I love that idea. Let's see who wants